MedStar Health is a 10-hospital system in Washington, D.C., to give you some background. And we're about 300 outpatient clinics, approximately $6.2 billion system, not-for-profit system. And as part of that system, our academic partnership is with Georgetown University. So we work very, very closely with the medical school at Georgetown. And we have one of the largest residency programs in the United States. So this environment here is our clinical environment. This is where we do all of our research, all of our primary work. And the MedStar model looks something like this, which is we have a very big focus on research, which is with the MedStar Health Research Institute, a big focus on innovation, and also on simulation and training. It's very similar to what we have here at Valdecilla. And the central goal is that each of those parts should be feeding the operational impact, should be feeding health outcomes. Our center, the center that I serve as director for, National Center for Human Factors in Healthcare, really sits right at the intersection of research and innovation. I'm going to start talking a lot about what human factors is and how we apply it, specifically with technology. So now we're in a phase where there's probably the biggest technology transition medicine has ever experienced. And we'll talk about how that's impacting patients and how that's impacting all of our clinicians. So our center now is about 30 people, and we focus on applying human factors to improve safety, efficiency, and quality of care. And our model is quite different from what other people do. We have human factors experts, but also clinicians, computer scientists, engineers, data scientists, and they all work collaboratively with this goal. And we try very hard to bring people in from other industries. So prior to coming to healthcare, I worked in the defense industry. We've had people that come from transportation, from nuclear energy. And the central concept is that we have to bring in those different ways of thinking if we're going to tackle the difficult problems in healthcare. So it's this multidisciplinary approach and cross-industry approach. Okay, aquí es el principio más importante de factores humanos. Es muy fácil. No podemos rediseñar los humanos. Es muy difícil cambiar los humanos. Entonces tenemos que cambiar el sistema. Tenemos que rediseñar el sistema. ¿Y qué es el sistema? El sistema incluyendo la tecnología, los procesos, different kinds of tasks, different work, the environment, and la organización. So these different parts is what shapes how we practice medicine. If we don't think about each of these different parts of the system, there's no way we can make the right change. So usually what we do in healthcare is if there's an adverse event, if there's a safety problem, we usually go directly to the clinician, to the nurse, to the doctor, and we say, you did this wrong, and you need to fix it. And we blame that individual person. We don't think about the whole system and all the parts of the system. We don't think about how we have to redesign that system. That way of thinking is completely different from almost every other domain that we have. If you think about transportation, aviation, your car is designed to work exactly how you work. The advancements in safety in vehicles, seatbelts, airbags, new alarm systems to tell you when cars are nearby, that is all because they're advancing that technology based off of how humans think, how they do their work. Same thing in aviation, same thing in consumer electronics. Your mobile phone is designed for how you work. But in healthcare, most of the technology is not designed that way. So we have to change the way we think about healthcare technology. We have to change the way we think about our processes. So let's talk a little bit about what is happening with technology in healthcare. You can now have all of your health information on your phone if you want it. You can have your watch that's taking your heart rate and transmitting it to your phone and then transmitting it to your doctor. We now have these telehealth appointments. I don't have to go to the hospital anymore. I don't have to go to the clinic anymore. And in the US, we have invested $40 billion, $40 billion in the electronic health record, in the EHR. $40 billion. And we've moved electronic health record adoption. In 2010, it was about 10, 12%. Now it is at 99%. So every doctor and nurse is using the electronic health record. $40 billion. I want to show you an example of what $40 billion buys. Okay? $40 billion. So in this scenario, we ran a study. I'm going to show you an electronic health record that cuesta $1 billón. El hospital paga $1 billón por este sistema, electronic health record. This is the actual system that is used by the doctor. And in this scenario, the doctor wants to order Tylenol. ¿Qué es la palabra en español? Gracias. Sí. It's Tylenol. Tylenol 500 milligrams. It should be a very simple order. Tylenol 500 milligrams. Okay? Okay. So primero, I type Tylenol in the search window. $1 billón para este sistema. Y hay 86 selecciones para Tylenol. 86. Y este es un hombre, el paciente es un hombre que tiene 25 años. Y hay Tylenol por los niños, Tylenol por las mujeres, 86 selecciones. Entonces, el doctor pone Tylenol 500. So they want to, it's too hard to read 86 options. Think about how much time it takes to look through 86 options. So the doctor types in Tylenol 500. He wants to narrow the search. So when he types in Tylenol 500, 0. 0 options. Because the way the system is designed is it has to exactly match the medication. So he would have to type in Tylenol 500 milligrams, and then maybe he would get that option. So the doctor will go back and delete the 500 and keep just Tylenol, and then searches through the 86 options. Okay, and then makes a selection. So this problem is everywhere. And the problem is the technology, when it was designed, didn't include thinking about how doctors, how nurses, how other clinicians actually use the technology. So what we're seeing now in the United States is a huge number of safety problems because of the way the technology is designed. So how do we fix that? So what we do is we focus a lot on usability and what's called user-centered design. And the idea is that you have to work with clinicians, with the end users of the technology, to actually come up with a good design for the technology. So this process includes studying the clinical environment, going in and observing how clinicians do their work, watching nurses and physicians do their work in the emergency department, in oncology, in urology. They're all different areas. We have to watch how they do their work. We then want to create different kinds of prototypes, and we need to put that back in front of those clinicians. We have to get their feedback on that technology. We have to understand how they're using it and refine the technology based off of how it should actually be used. This process is used by Amazon, it's used by Apple, it's used by every big consumer company that needs to gain business and build a great product. But it's not used in healthcare as much. So, esta es un foto, es mi favorito. Okay? A la derecha, la tecnología, y nadie mira la tecnología. A la izquierda, a whiteboard, dry erase board, cuesta $50, $100. La derecha, $1,000,000. Why is everybody using the whiteboard? Because it supports the way they do their work. It was built over time. So the nurses use some X's to indicate when a patient just arrived. They maybe use a circle to indicate when a patient is leaving. The environmental staff can put a check mark when the room is clean. The doctor can easily write their notes, letting people know the status of the patient. That system, that process, was created by the clinicians. Nobody came in and told them how to create the system. It emerged from the way they work, and it works very well. With the technology, some technology developer who doesn't know a lot about medicine is coming in and saying, here's how you have to do your work. So now all of the clinicians, the doctors, the nurses, the environmental staff even, have to change their process to meet the technology. And when we do that is where we have errors, we have inefficiencies, and we have clinician frustration. So when we talk about usability, we usually talk about the design of the interface, the design of the screen. And the science of human factors has very clear guidelines on how to do this. No usa amarillo and blanco with text. Basic rules. These rules apply in aviation, they apply in healthcare, they apply in transportation. Very basic rules. We have to follow those. The harder part is what we call cognitive task support. This is understanding how nurses do their work, how clinicians, how doctors think about information. This is thinking about when they need information when they're doing their work. To learn this, you have to go into the environment, you have to go into the clinic and work with the doctors and work with the nurses to build that understanding. And what we know in oncology is different from what we know in emergency medicine, and that's different from what we do in primary care. So we have to make that investment if we're going to build great technology. So what happens when we have bad usability? What we're seeing in the United States is patient harm, la seguridad del paciente. In los Estados Unidos, we have clinician burnout, and a lot of inefficiencies. It's taking us longer to do certain tasks. So these are what we see now in the US. These are some of the headlines from prominent newspapers. More frustrations around the electronic health record, the doctor and the nurse spending more time in front of the computer and less time with the patient. And then this year, on the cover of Fortune magazine, is a big story on the safety problems with electronic health records. And this is the trend or the pattern that we're seeing when we look at adverse event reports or safety reports. Remember, in 2009, 2010 is when $40 billion were invested. Now that 99% of providers are using an electronic health record, we're seeing a big increase in the number of safety events related directly to the technology. So I want to share some of the research that we've been doing in this space. So this is a paper that we published in 2018 in JAMA, where we looked at nearly 2 million safety reports. Es lo mismo de Synapse, este tipo de text. And we looked for reports these are reports that come from across the United States. And we looked for reports that specifically talk about the use of electronic health record and an error from the electronic health record. So here's one example. En este escenario, un doctor prescribe una medicación y un otro doctor prescribe lo mismo medicación. Entonces, el paciente recibe dos. With the electronic health record, the system should know that. The system should be able to tell that 2 medications have already been placed on a patient. This was one of the main reasons we went to electronic health records. So the system should alert the physician, the doctor, to let him know that a medication of this kind has already been placed for this patient at this time. This is a basic usability concept. So we looked through these 1.7 million reports and looked for specific cases that mention the electronic health record. It has to exactly say an electronic health record was used, and describe an event that's related to usability. These are all the different kinds of usability problems that we found. So at the very top is difficulty entering information into the electronic health record. Like I showed you, typing in Tylenol. Trying to enter any information in the electronic health record should be very easy. We find lots of difficulties. A problem with alerting. So when the system is trying to give the doctor or nurse information, it should be very easy to alert the clinician. Interoperability, connecting the information between systems, should be usable information that's connected. Not all of the information, only usable information should be connected. The way information is displayed, I showed you that screen that had 86 options for medications. Many of those medications are not even relevant for the patient. A male patient, 25 or 26 years old, we don't need medications for children. We don't need medications for women. That all creates this visual clutter and creates frustration and creates more likelihood for error. The availability of information is making sure that only the most relevant information is there for the doctor or nurse. System automation and defaults. So there are some examples where a doctor placed an order for a medication and the medication doesn't start till the next day. And it's not clear to the doctor that it doesn't start till the next day. And then supporting the overall workflow of the doctor or nurse. So we took each of the reports and we categorized the report into one of these specific usability issues. And here's the results of that. So you see that the majority of the errors are related to data entry, a lot of errors related to alerting and interoperability. And this is happening primarily during any kind of order placement, medications, labs, diagnostic images. During that ordering process is where we see the majority of errors. And a lot of these errors are also happening during the medication administration process. So we're seeing a lot of trouble with the usability directly tied to patient safety. Now, in the United States, to move any kind of policy con el gobierno, necesita un ejemplo con los niños. So we did another study where we looked specifically at pediatrics. And we looked at electronic health record medication problems with children. And we found the exact same issues, the exact same problems. That children are being harmed and sometimes dying because of direct errors and mistakes from poor usability of the electronic health record. And the electronic health record for pediatrics needs to be designed differently than for adults. You have more problems with weight-based dosing. There's a whole host of differences. And if the technology developers aren't accounting for those differences, we get a lot of errors that happen. So $40 billion, and this is what we get. Now, we have the same problems in the United Kingdom, same problems in Australia, same problems in the United States. So we have to learn from these mistakes. There's a big opportunity to learn from these mistakes. I want to share one other example of another study that we conducted last year. And here we looked at 2 products from Cerner, which is one of the largest EHR vendors, 2 products from Epic, which is the largest electronic health record company in the world. These technologies, again, cost the hospital cerca de $1 billion. And here we created 6 different clinical scenarios, and we went to those hospitals and we had emergency physicians, emergency doctors, use their electronic health record system to complete these scenarios. So for example, one scenario might be order an X-ray for the left forearm and wrist. Another scenario might be a patient comes in with back pain, prescribed Tylenol 500 milligrams, etc. And we conducted this usability study with between 12 and 15 physicians, and we recorded all the information you can imagine. How many times they're typing, how many times they click the mouse. We used the eye tracker to collect where they're looking on the interface. And we looked at the differences between the sites. And here's the data. You can see for each of the different sites and the different vendors that they used. And we didn't want to say the vendor names, but you can see the 4 different sites. And for something very basic, like placing an X-ray order using the computer, for the left elbow, wrist, forearm, you can see the error rates. So uno es 35%. 35% error rate. And that error could be ordering for the other side, ordering for the right side, the right arm, ordering a different part of the arm. When we look at the medication orders, a prednisone taper, cuando reducir medicación con tiempo, 50% error rates. And these are the systems that are used today to treat patients in the United States. 50% error rate. Now, thankfully, what happens is many of these errors, medication errors, they get caught by pharmacy. The nurse recognizes the error, so the patients aren't always getting harmed. But you can see how the design of the technology directly impacts the kind of errors that are made, the kinds of problems that we have. So I want to share now, that was all focused on the impact of technology on the patients. Let's now talk about the impact of technology en los clínicos, on clinicians. In the United States, we now have a national problem of clinician burnout. So many of our doctors and nurses are committing suicide, they're leaving medicine, they have depression, they're overly frustrated, they're having family problems. And part of it is because of the type of work that they have to do, and we believe that part of it is because these new technologies have become so hard to use, they're getting very frustrated. So what we created is a heart rate sensor that we put on our doctors during their shifts. So in this short study, we put it on 4 different emergency doctors for their 10-hour shift. And then we send in an observer, we send in a researcher, and they use this kind of tablet device, and they track every task the doctor is doing. during those 8 hours. So if the doctor's working on the computer, they tap that task, and this tablet records the amount of time the doctor is spending on that task. If the doctor then goes to see a patient, they tap the patient button, and it records that information. So now we have the physiological response of the doctor, the heart rate, and we have the actual tasks the doctor is doing. And we want to see what are their heart rates like. So heart rate's not a direct connection to stress, but it can be an indicator of the kind of stress that the doctor might be feeling. So here's the data. Some of the heart rates were as high as 160 beats per minute. Puedo correr cerca de aquí, and I can't get 160 beats a minute. There are 2 tasks where we saw these high heart rates. One was using the electronic health record. When they have to get in front of the computer and enter the prescription information, we see their heart rates go up. Now, there's a few reasons for that, probably. One is in the emergency department, it's a very busy environment, so they may be getting interrupted by nurses, by other patients, by other doctors, so there could be a lot of stress coming from that. That's driving the heart rates. And then we know that the electronic health record can be very difficult to use. And so that frustration from the technology is being reflected at a physiological level, is what we think. Now, this is only with 4 doctors. We just completed a study with 18 doctors, so we'll have some more information here. But our early belief is that part of this is the poor design of the technology is leading to increased physiological response. There's a second time when we also saw high heart rates, and that second time was when the doctor was talking to patients. So that communication can be very stressful. I think there's a big opportunity here to also study this in simulation, to really understand and to train our physicians and our nurses to reduce that kind of stress that comes with that communication, to practice. So I want to close by talking about the bright side, how we can make this technology better. And for the last 3 years now, we have been partnering with not Joe Igalo, with Idival, with HVV, and they've created EvalTech, which is focused on how we can use these principles to better design the technology and, importantly, better integrate that technology into the clinical environment. If you talk to experts in the United States, you talk to experts in the United Kingdom who are now doing their second round of the electronic health record, they will all say we should have used usability and human factors earlier in the process. Instead of investing $40 billion, start with $5 billion and do a pilot study and learn from that and improve the technology over time instead of investing $40 billion and trying to use the electronic health record across the entire country. So in this so far 3-year partnership, this team the EvalTech team has grown, has developed a lot of expertise, has published a lot of papers, has started giving a lot of presentations, a lot of workshops, and now has made meaningful contributions on several different projects. And so as Spain goes through this technology transition, it's going to be very important that human factors and usability is the central focus of that. And I think it's very important to also recognize in the United States, if you ask doctors, do you want to go back to paper? Do you want to stop using the electronic health record? 97% say no. They want to use the electronic health record, but they're frustrated with the electronic health record. In their experience in any other domain, if you're making an airline reservation, if you're using Amazon, if you're using your Apple iPhone, It's easy. So they're expecting that this technology in healthcare should also be easy. And we should be working to make sure it's easy. So we're looking forward to continuing our partnership here. We're looking forward to continue doing this kind of work. And ultimately, we believe it's going to improve patient safety, improve patient outcomes, and importantly, reduce that clinician burnout, reduce that frustration. Thank you very much.